Hello, everyone, and welcome to the Illinois Wesleyan University Titan Talks webinar series. I am Adrienne Powell, the Director of Alumni Engagement, and I'm so pleased that you all are joining us today. We're excited to provide this platform as a lifelong learning and engagement opportunity for the Titan community. Please mark your calendars for a few upcoming webinars that we have scheduled. On August 20th, we will introduce the School of Music Director, Professor Franklin Noray. And then later in August, we'll host a panel of alumni working in various fields in mental health and social work to discuss the emotional and psychological challenges that we all are facing during this difficult time and how to stay mentally healthy. That panel will be at noon Central Time on Tuesday, August 25th. And more information about those will be coming your way. Now for some logistics. For this webinar, all the attendees are muted, except for our panel, of course. You are welcome to participate through the chat function. There will be a brief Q&A after the conversation, so please use the chat tool to send any questions you may have, and Professor Folse will try to get to as many as possible. Also, in case you have to leave early or if you would like to share, this webinar will be recorded and posted for later viewing. I'd like to turn it over now to our moderator, Dr. Vicki Folse. Vicki is a 1986 graduate of Illinois Wesleyan, and she now is professor, director, and the Caroline F. Rupert Chair of the School of Nursing. She is also serving as the Interim Executive Director of Counseling and Health Services. Thanks so much, Vicki, for participating, and I will hand it over to you.
Thank you. I'm going to begin by talking about our three esteemed panelists. I want to begin by introducing Dr. Benjamin Killey. Ben graduated from Illinois Wesleyan in 1999 with a dual degree in piano performance and biology. He's been practicing emergency medicine since 2003. He attended SIU School of Medicine and completed his internship at the U of C. He did his emergency medicine residency at Cook County in Chicago. He began practicing in the state of Washington in 2007. Most recently in May, Dr. Killey volunteered as an ER doc with the COVID Care Force, which was designed to quickly mobilize groups of healthcare providers to deploy to hotspots and to provide critical staffing for shortage areas because of the pandemic. After joining this organization, he quickly flew to the Navajo Nation in New Mexico, and he's got some great stories to share with us. Many of you may be aware that the Navajo Nation is the largest Indian reservation in the U.S., and at the time of his arrival, it was the third highest coronavirus infection rate in the U.S. In addition to Dr. Killey, we're joined today by Dr. Paul Peterson. Paul is from the class of 73, and he practices internal medicine and is the VP and Chief Medical Officer at OSF St. Joseph Medical Center here in Bloomington. After Illinois Wesleyan, he attended U of I College of Medicine, and he is just a servant leader in our community. He's been on many panels and committees, McLean County Medical Center, in which he's very active and has served as president from 95 to 96. He's on the board of the Rural Illinois Medical Student Assistant Program. He is with the Community Healthcare Clinic, and most importantly for today, Dr. Pedersen has led OSF's effort to prepare for our local COVID-19 cases in the area. And our third panelist today is Janna Morgan. Janna is a 2010 graduate from the School of Nursing. She's practiced in many different areas of nursing, from long-term care to critical care. Her passion for critical care has been intensified as she's joined the COVID front lines as well. She accepted her first COVID assignment in May of 2020 as an independent nurse contractor at Northwestern's Lake Forest Hospital, where she worked in the COVID ICU with COVID patients and remotely their families. She's currently earning her master's degree to be an F&P and plans to finish that by 2022. So we have three panelists with us today with a variety of backgrounds, and I'm confident that you'll find their answers to questions in their conversation very informative and quite inspirational. So I want to begin, panelists, by asking an overarching question that I'm respectfully asking all three of you to answer. Can you start by talking about your day-to-day work and what impact this pandemic has had?
Well, for me, just from the nursing standpoint, day-to-day now we have to wear a mask, like a regular surgical mask. Even when we aren't doing patient care, we have to wear a mask when we're at the nurse's station, things like that. And also, we're used to having our IV pumps inside the room with regular patients. Yes, those masks. But with the COVID patients, because they want to limit our exposure to the patients and to the virus, the pumps are outside the room. So of course, there's like infection control things that go around that. There's extension tubing that extends from the patient to the pump outside the room. And then also, just with charting, they have now what's called crisis charting, so we don't have to chart as much as we typically do on a basic day. Even though we do have the crisis charting, I still choose to chart fully. But that's a little different. And then also the patient ratio. So typically in the ICU, the typical patient ratio is 1 nurse to 2 patients. But with this pandemic and also the lack of staff, sometimes the ratios can be 1 to 3 or 1 to 4. And in the areas where there are 4 patients to 1 ICU nurse, I know some hospitals have paired that ICU nurse with a med-surg nurse, so that nurse can do those duties like giving meds during the bath, things like that, while the ICU nurse focuses on titrating IV medications and the ventilator.
I guess I can go next. I think the biggest difference for me as an ER doctor is mostly just wearing the correct protection when I go to work. So from my standpoint, I am pretty concerned about the risk of breathing it in. And so I usually put my protection on before I even walk into the hospital. It's not really based on the patient in front of me. So before I enter the hospital, I put on an N95 mask. I put on a surgical mask on top of the N95 mask. There is a pair of eye goggles that I put on to protect the mucous membranes of the eye. Then I put on a hair covering, and that's what I put on before I even set foot into the hospital. And once I'm in there, that does not ever come off. I don't touch my face. I do not touch the masks. It is on the entire time. The only thing I change kind of between patients is right now we have also added a plastic face shield that covers the face and the neck that we have on before you see any patient unless they're confirmed negative. So if someone has had a negative test, then you can take the shield off, but I'm still wearing the N95 and everything else. But realistically, I just put on the face shield at the start of my shift and I leave that on also.
Starting in March, the biggest challenge that I had was from my administrative side, and that was how to get the appropriate amounts of equipment for the people who are needing it. Those caregivers at the sharp edge of care, both physicians, nurses, techs, housekeeping, all of those folks. And the second piece was, when do we get enough tests to be able to test people appropriately? And working through those logistics to make sure that we had those things covered to the best degree that we could. Patients coming in that are questionable, and there were many of them, you're going to put those patients into isolation regardless of your ability to test, and now you're burning through PPE and everything else that both Janna and Ben have mentioned, and until you run out of it to a certain extent. And then it's into conservation mode and figuring out how to recycle N95 masks and working through those problems. That was the first 2 weeks of this pandemic, plus getting the community to understand what pandemic really means.
Mhm.
This isn't going to be over by, next Tuesday.
Mhm. You're describing situations that many of us thought were limited to underserved or underdeveloped countries in terms of the lack of access to personal protective equipment. And I'm wondering, as the three of you talk about how you're maintaining your own personal safety, which in turn helps assure the health and safety of patients, families, and other visitors. Could you expand on Dr. Peterson's statements about our initial deficits in terms of PPE and what you're seeing in the areas in which you practice? So both protective equipment and, as Dr. Peterson began, access to testing.
Yeah, it's definitely evolved as the pandemic has changed. I remember back in February, March, when this was first coming out, and I don't feel truly understand how contagious it was or the ways it can be contagious. And initially it sounded like, if you think your patient might have COVID, then put on a surgical mask. If that person needs a high-risk procedure, like you're intubating them to put them on a ventilator, then put on an N95 mask and eye protection and all that other stuff. And I think initially that recommendation was there because there was a limit to how many N95 masks there were in the hospital. So, for myself, I actually have a private clinic on the side. I happen to have 8 N95 masks of my own, and I brought them to work. I wore my own N95 mask, and I wasn't about to take it off. Now, subsequently, because there was a pretty good job of preserving the PPE, and because we were able to, I think, initially blunt the curve in this country, manufacturing caught up to a degree. And so, at least right now, we're not experiencing any shortage of masks. And we also had a lot of people donate their N95 masks to our hospital. We had construction companies donating and local clinics donating. And right now the masks are not in shortage. I think other things have come and gone in terms of what's in short supply. And right now I think the disposable gowns are a little hard to get a hold of, and disposable gloves are getting hard to come about. We have not run out of it in my hospital by any means, but I know it's kind of on the radar as the next thing to be concerned about.
So both in the Navajo Nation and now in the state of Washington, you're describing adequate supplies. And again, I'm thinking back to the images of healthcare providers wearing garbage sacks as their hospital gowns and stating that they were reusing their disposable mask or coming up with makeshift PPE.
Mm-hmm. Yeah. And initially when this all started, the recommendation for N95s was still you use it one time. You walk in the room, when you leave, you throw it in the trash. Which now seems completely insane to do that. You hold on to that mask and you protect it, and that's why we're wearing the second mask on top of it to protect the bottom mask. So.
And Dr. Pedersen, as an administrator, is shaking his head because he knows the cost of each of these pieces of equipment.
Yeah, you bet. And we since we weren't doing anything other than emergency surgery, our sterilizers were not very used at that point. And so we figured out, oh gosh, you can put those N95 masks into a sterilizer and sterilize them again, and it works. The biggest challenge was making sure that because the makeup doesn't come off. And so nursing staff, nobody wanted to wear anybody else's mask, so you had to make sure that you put it in indelible ink and wrote on it to make sure it was yours, because nobody wants to wear your makeup.
I know for me at Lake Forest, prior to me taking the contract, they said that they were limited on supplies and they were locking stuff up because people were stealing masks and all kind of other things. And so they had to lock the supplies up. But then when they hired about 50 nurses to come in to help, they also bumped up their supplies. So we were never without any supplies or masks or gloves or anything like that. But with the patients who were on the vapotherm, that's the heated high flow oxygen, we would have to take our masks and throw them out and get a new one each time because they were aerosoled. But the patients who were on the ventilator, we would just reuse them. We would put them in a brown bag, put our name on it, and use that same mask for the 12-hour shift. So I can definitely see how it can be very wasteful, especially if a patient is on a ventilator and the virus isn't aerosol. If you're just going to be throwing out each time, I mean, that is a lot of money. So that idea about sterilizing the masks, that's a very good idea that I feel a lot of people that actually use to save money.
Yeah. Would your assignments, the assignments, Janna, that you accepted, did you ask about the adequacy of PPE and the safety precautions?
Because at the end of the day, you know, I could just stay home, but I love what I do, and I didn't want, because the media, like watching the news and everything every day, I was becoming very fearful because I didn't know like truly what was going on in the hospital. I said, you know, I'm going to take this to see what's really going on. And so I know there are some places still that have low supplies and they're making you reuse the mask every 5 days and such. But, you know, me living with my parents and they're a little older, you know, that's a major concern for me. I want to make sure that I'm protected so that they're protected too. So if there's a place that doesn't have adequate supplies, I tend to not go there, honestly, because at the end of the day, this is my life, it's my safety, and it's my choice. And so that's the one question that I always ask, always.
Ben, let me direct the next question to you because of your experiences with the Navajo Nation in New Mexico. We've seen a racial disparity in how COVID affects different populations. And it's particularly true for First Nation and for Black populations. Can you tell us what you saw and what you experienced?
Yeah, I don't know. Well, what I can tell you is that it seems like that does go hand in hand with poverty, which goes hand in hand with a number of medical conditions like diabetes and asthma and obesity, which are the same risk factors for the people who do poorly with COVID. And that's what I saw at the Navajo Nation. And it's not just COVID. So, I mean, historically, that population has been really vulnerable to all respiratory illnesses. They have a really hard time with influenza every year, and COVID is no different. So if half your population has asthma or diabetes, and then it goes racing through the population, the outcomes are generally much more poor. Second of all, though, when it comes to things like poverty, there are a couple of other issues. You have healthcare, lack of resources, and you also have lack of resources at home. From a home standpoint, what I thought was, I guess, the most shocking to me, because I did not know really anything about the Navajo going into it, except what I learned in my little orientation booklet, but poverty is pretty prevalent, and some of the basic resources that we expect in the United States are not there. So the Navajo Nation is pretty huge. It's about the size of West Virginia. And if someone lives close to one of the major interstates that are going through there, those people generally have the usual resources you would expect, like electricity and running water. But once you get inside of the territory, it is really common to not have running water or electricity. And they're using outhouses, and they have no way of washing their hands. And they live fairly remote from each other. They don't tend to be in clustered living. They tend to have individual homes with 3 to 4 generations living together. So you take a small home, you put 12 to 18 members of the family together with no running water, and it just takes one person to get COVID, and then all 18 of them are going to get it. And you try to recommend, yes, just socially distance yourself or wash your hands all the time. And it's just not realistic. It can't happen. And so that's where it just became like wildfire and kind of spread amongst the people.
And I'm wondering, Janna and Paul, if you've had experiences as well with marginalized populations, and if the three of you can offer us some insights into what we could do better as a community.
Certainly, there is a challenge with our marginalized populations, without question. Part of that is education-based. Part of that is poverty-based. Part of it is the living situations that have been identified. And in many of those populations, there's an intermixing as well of different families. They may live in and stay in one house tonight and stay in another one tomorrow night. And that intermixing, I think, certainly creates a lot of the challenge in physical distancing.
I mean, honestly, just to piggyback off of what Paul and Ben said, education is the major thing that I see that needs to be done, because I've had patients come in and they're on 100% oxygen. And they're like, well, I just want to go home. I feel fine. I can be around my family. I'm like, but sir, when you're off the oxygen and you're just shuffling in bed, your O2 sat is like 75%. So no, you aren't well enough to go home. And then, you know, just me personally, I do my best to give education on how they can prevent the further spread of it when they actually are able to be discharged and go home. I've honestly seen more women go home and be discharged and taken off of the oxygen and the ventilator than I have men, which is something that I've observed. And they tend to do a little bit more better at home. I've been having to kind of have some tough love with the fellas to try to get them to prone and do other things that they need to do when they're being treated. But education, I feel, definitely is a major piece that needs to happen that we could do better with. And also just finding ways that we can give people better access to the resources that they need. Because a lot of people end up back in the hospital because they either don't have money for the medications or things that they need, or even access to be able to get them.
This pandemic has certainly exposed challenges each of us are aware of in terms of access to care and the disparities that we see in different populations. We could do better. So I gave you a shout out, Paul, earlier about your administrative role and you know what we need to think about. What have been some of your greatest challenges administratively?
Physicians are a wonderful group of people, but we also tend to have our own mindsets about certain things. And decreasing that variation in mindset about how to wear an N95. Oh, by the way, that N95 that you got from Korea that doesn't fit your face isn't functioning very well.
But it may have fit my face 20 years ago.
Exactly. Getting over some of those kinds of physical challenges about that has been very challenging to get physicians to understand that.
Mm-hmm.
That's true. And you know, what's interesting about New Mexico was on the first day I was there, their physicians gave us kind of an orientation day to their hospital and everything. And there was an hour dedicated just to the correct way to put on your proper PPE. So your N95 mask, covering your hair, gloves, gown, and then the correct way to take it off without contaminating yourself. Because it's thought that a lot of healthcare workers are actually getting sick from taking off their contaminated masks or gowns. And it was the most comprehensive and straightforward talk I've ever had on personal protective equipment. And I felt completely safe the entire 2 weeks I was there because I was going through the step-by-steps that they had taught me that it's fairly intuitive, but some things you don't think about. And I do think it was a great education. I've tried to tell everyone I know at work now in Seattle, you're not doing that N95 the correct way, or just be aware you just touched this part of your body or whatever. So it is good to have that kind of education for healthcare workers.
And I think if you compared the nosocomial infection rate amongst healthcare workers who followed those kinds of edicts about how to put things on, making sure that you're washing your hands frequently, don't touch your face, all of those things that are pretty simple, frankly. But you got to follow them all, and you got to do it all the time. I think when you look at those nosocomial infection rates amongst those folks, it's really low if you do that stuff appropriately.
Sure. Even on campus in the spring, we did a campaign to help our students who were staying residential wash their hands and don a mask properly. And I was struck by the health literacy challenges of what it meant to wash your hands thoroughly for 20 seconds and what that looked like for Illinois Wesleyan students who of course we know are bright and would be reading all the CDC information, but we had to do some, I would say, pretty basic, here's how you wash your hands, here's how you put on just a cloth mask properly. And I think we forget that we don't always offer that level of education. Janna, were you going to add to the comments of your fellow panelists?
Oh, they pretty much covered.
Okay, great. Well, while you have the microphone, let's talk mental health. That's a passion of mine.
Yes.
But what have you seen with your fellow coworkers? You've had the benefit of going to different organizations. How are we doing as a group of healthcare providers?
Well, I would say overall, nurses, we're so resilient and we make jokes out of everything to laugh and cry a lot of times. But there's a lot of mixed emotions, there's sadness because we do see patients that are dying by themselves who don't have their family present. We see patients that have been there for months fighting this virus and they end up not doing well. Some end up doing well. We're happy when the people get better and we get to discharge them and celebrate them leaving. We have people that are fearful of getting COVID and bringing it back home to their families and their loved ones. People who are just angry because they don't understand, like, why is this even happening? Why there isn't a vaccine yet, why there isn't a cure yet. So it's a lot of mixed emotions, but overall, everybody just wants to fight and they want to make sure that everybody's cared for, that they're cared for. And, it helps when the community sends us food and sends us like nice cards and just show us how much they appreciate us and they honor like what we're doing. I mean, honestly, this is the first year I can honestly say I'm the most proudest to be a nurse because people actually acknowledge what we do. We do a lot. And I'm very grateful that people really see what it is that we do beyond just wiping butts, because that's what a lot of people think that we just we do a lot. And I'm so grateful that like this whole pandemic has opened up and shined a light on what it is that nurses do overall.
Agreed. Ben and Paul, what have you seen with regard to the mental health of your colleagues?
First thing, I think it would be helpful if we change the wording from social distancing
to physical
distancing.
Yeah.
Social distancing means, in addition to physical distancing, that we are cut off from our fellow people. And humans are herd animals. We're not, grizzly bears living on a mountain and not connecting with anybody else. We're better when we're together. So the social distancing needs to be addressed and make sure that we're connecting like this, using these kinds of technologies with each other when we are physical distancing. that's as true for our colleagues as it is for our patients and our families, and making sure that we do that.
I actually kind of agree with what Janna said earlier, where I think a lot of my colleagues are having a higher job satisfaction right now because you feel like you're actually doing something worthwhile that's making a difference. And emergency medicine especially is a fairly high burnout rate, and I have definitely felt that. And when you actually are appreciated by patients, they're there because they need help, you do feel like you're making a difference in their life and you enjoy going to work more. Initially, there was a decent amount of fear, like in March, I would say, even amongst my colleagues, like we didn't know much about this germ. We'd seen one of our colleagues in Puget Sound be put on a ventilator as an ER doctor, and there was kind of a chilling effect for all of us. But now that we all kind of know the way to protect ourselves and we're kind of seeing the effect of this later on, I think we're all doing a little bit better.
Mm-hmm. Well, let's segue into how we protect our families or others. So personally, have the three of you experienced concerns? Your family doesn't want you going into work. They're concerned about what you might bring home, the number of hours you've been putting in since this pandemic has occurred. Give us a personal glimpse into what this is like for people who surround you and support you.
I guess for me, I have roommates, so I do consider that a risk. And like, for example, before I went to New Mexico, I floated the idea by all of them and said, would you freak out if I go to this pandemic center and live in a cloud of COVID for 2 weeks? And none of them actually had a problem with it. They knew I would do what I need to do to protect myself. But I was obsessive about protecting myself because I knew if I get it and I take it home, all of them are going to get it. So I took pretty extreme measures. I told you what I do during shift, but when I would get back to the hotel where I was staying, I would only go about 2 feet inside the door. Then everything was coming off into a pile, and then I would shower. Then I'd put gloves on to even touch the used scrubs to put them in a bag. And what I was doing with my N95s, I brought 5 of my own just to make sure I had protection. I had them lined up on an air conditioner unit in the window because sunlight kills COVID. So it was on a 5-day rotation where for 5 days it would get hit by sunlight and before I would use it a second time. And after I put the scrubs in a bag and put the mask back on the air conditioner unit, then it's wash your hands again and then alcohol your hands. And then I would eat and drink. I was not eating or drinking during shift. I wouldn't eat or drink until after that whole routine was followed. In Everett, Washington, where I practice, it's not quite so extreme because now our cases are few and far between. But still, just kind of the daily practice at the end of the shift, I'll go to my car and I take off the masks, you get rid of your stethoscope and things like that, my hospital ID, and I put it in the trunk of my car. And I do not touch it for 48 hours. And at that point, then I'll take it out of the trunk, then I'll put it in the laundry or whatever. But you just have to be, I think, kind of cognizant of, things that could potentially be contaminated and just don't let it inside the house until you're sure it's safe.
I agree with Ben. They have scrubs for us at the hospital. So we go in like our own clothes or scrubs and we change into the scrubs that they have there. And so I would do that. I would wear shoe covers. My hair is always covered with a bonnet that someone actually made and they donated a bunch to the hospital for the nurses. And then after my shift, they had showers there. So I would shower before I left the hospital, but then it got a little tedious. So like Ben, I would just go back to my hotel room. Luckily, the organization that I'm a part of, they had free rooms for a month for frontline workers. So I chose to be physically distant, as Paul said, from my family because I wasn't quite sure how things would go. So I chose to stay physically distant from them while I was working. And I would go in my room, I'll take everything off, put it in a bag, and then shower, and then I would eat and everything like that. And even with my work shoes, I would leave them at work in a locker. My work bag, I would leave in my car, or if I brought it into the room, it's right there by the door, so it doesn't go further into the room. And then even after the contract is up, I would stay away from home for about a week in a hotel by myself, just to like self-quarantine, just to make sure that I was okay. And another one of my agencies, they require for me to get COVID tested every few weeks. So I have to go do that. But that's pretty much what I do. And whenever I start my shift, I cavity wipe everything, like the desk, the chair, the keyboard, the computer screen, my phone, my pens, like everything.
Sure. So Ben described seeking approval from his roommates that they wouldn't freak out if he made that decision. This must be hard on your family to have you away. What have they voiced?
Well, my dad is the main one who was like, I don't want you to go. Like, he likes me to be close by, but he understands that he knows that this is my passion and my love. He said, you have to go where you have to go, and I know that you'll be safe, and you'll do what you have to do to protect yourself. So, you know, they just always want me to call in like after work to make sure I'm safe in my room and just checking in on me. But they already made an action plan. They said, you know what, if you get COVID, you can come home and we will isolate you to the main suite, and you just stay up there. And if we get it, you know, we pray that we don't die from it, but we aren't going to just let you be away from us for that long. I said, okay, I understand, but I'm still going to physically distance myself just to make sure I'm okay before I come back home. So.
And Paul, how about the people in your life?
We stayed away from our grandchildren who go to daycare. We stayed away from them until just recently. And while they didn't have any major issues in their daycares, we still stayed away from them, and then used FaceTime or Zoom to socially interact with them. And that became a very nice opportunity. At home, in particular, between my wife and I, we had a discussion, and that was that if either one of us developed symptoms, you know, even early starting symptoms, we would probably separate ourselves into different levels of our home, so that. But we have the opportunity to do that. Not everybody does.
Right.
You know, when you're living in a home that's got one bedroom, you know, a 10 by 12 maybe family room and a small kitchen, and you've got 5 people in there, as Ben mentioned, it's impossible to physically distance.
Yeah, we have privilege.
Yes.
Yeah. So let's stay on the topic of behavioral health and self-care. What can you share with our audience about what you've done for stress relief and for promoting your own sanity during this pandemic?
For me, what works is 2 things. I have a belief in a superior being, so I do pray, and that helps. Secondly, education, and as much as I can read about this particular virus, what everybody else might be doing and what is likely to work. And it turns out that some simple things seem to work pretty well. Cover your mouth. Don't cough and sneeze at other people. Wash your hands. Keep your hands away from your face. And be a little more physically distant. Gosh, who knew that would work?
For myself, I thoroughly enjoy exercise. It's one of the greatest stress relievers in my opinion. So I like to go on long walks outside in nature. So I'll go on a walk till I can't walk anymore, then walk back the opposite way, just explore. Meditation, like Paul, I believe in a higher being, so I pray a lot, meditate. I like to read. I love anime. I'm a huge anime fan, so I just get lost in anime and talk to friends and family and just catch up and just make sure that they know that I'm fine. And sometimes, you know, they'll ask me questions and they'll talk to me about things. So I'll share my experiences with them. And I also have a counselor that I call and I talk to and have sessions with. So that's very helpful too.
Then we're going to be disappointed if you don't start with music.
Well, I guess admittedly, I've actually played the piano less during the quarantine. I was playing a lot leading up into it. And I still do some, but, I need a goal to practice the piano a lot. And if I don't have a goal, I actually tend not to play a whole lot. So for me, interestingly, I feel like I've been less stressed out during this whole pandemic. And I think part of that is it's a slower pace of life for me. Like I don't have all these activities going on. I'm not planning trips, which are exciting, but it's also to some degree stressful. And when you're just focused on yourself and at home, and I've actually been less stressed out than usual. For me, I guess my main stress reliever is playing tennis. And at the beginning that was banned. They locked up all the courts, they took down the nets, and that was upsetting. But now it's back up, so I'm playing tennis again. And I just find that listening to podcasts and doing menial tasks like pulling weeds in my yard or cleaning the house while listening to this podcast, that's kind of my nice go-to stress reliever if I need it.
It sounds like each of you have become more deliberate in the activities that you choose and being more grounded and mindful of what brings joy and what can simplify our lives. Being at home for the last several months has changed that dynamic. I'm still working on working less, but it's an interesting change to think about being much more purposeful in activities. Okay. So let me ask each of you, has there been something surprising about what you've just experienced? And how does your experience differ from what we may have seen in the media?
I guess the surprise for me was that job satisfaction increased, and myself included when this first came out. I remember hearing the reports and coming out of China and thinking, oh my gosh, it'd be the end of the world that comes here to the US. And then actually the very first patient in the US was at my hospital, and there was a decent amount of fear and thinking about what could happen. And now it's here. Now we're used to it, I guess, and I enjoy my job more. And I definitely didn't expect that to happen.
Mm-hmm. A renewed sense of purpose and energy in a very stressful field.
Yeah.
I agree with Ben. And then also one thing that I didn't hear much about in the media was that patients were getting pulmonary embolisms that had COVID. And a lot of them were dying, not from the pneumonia, but from the pulmonary embolisms. So the blood just being so thick and clotty, that's one thing that wasn't really talked about much in the media. And so that was a surprise for me. So all the patients have the same tests, the D-dimers, the PT-INRs, the ferritins. And I'm like, wow, I had no idea about this. So for me, just educating myself more about the symptoms that we will see, and from a nursing standpoint, how to treat those and how to go about testing and things.
Sure, and going back to vulnerable populations and the number of our marginalized patients who come in with cardiovascular challenges. Yeah. Surprising, and Dr. Pedersen, as we hear about surprise and what's different about your experience from what we see in the media, we have a question from one of our guests. Scott Sebring wants to know what's changed for you with regard to the distancing from your grandchildren.
One of the things that changed was that we just spent 2 weeks with them on the Outer Banks, so that was nice. but they were all very asymptomatic beforehand. But what's changed now, I think, is the strong appreciation that there is the next time this happens, which isn't going to be very long, I don't think. I don't think this is going to be a 100-year cycle anymore. It's important that we prepare and make sure that we're ready for these things to occur, whether it's this virus, a different virus, or something that's much more lethal for us, so that we don't get surprised.
Mm-hmm. So it was surprising that we were so underprepared.
Oh, absolutely.
Not only as a healthcare field, but as a society. Thinking about how politicized mask wearing is, thinking about that the challenges we've had in trying to create public health best practices, and how many communities still aren't embracing what a deadly disease this is.
Yes.
Yeah. So, Janna, tell us about, you mentioned earlier that you saw patients without families, that you know, the No One Dies Alone movement just really hadn't solidified before COVID hit. So tell us about that in terms of what you saw, and Paul and Ben may have had similar experiences, but what was that like, watching patients without families?
For me, it was very tough, because I know the majority of patients that I cared for were Hispanic, and they have huge families, and they're used to their families being around. And there were some people that walked in and 2 hours later they died, and family wasn't able to be there quickly enough to be able to be there at their bedside to watch them pass, or to be with them while they pass. For me, even wanting to be in there with them, you know, I took a risk just being there and holding their hand, but I wanted them to have a presence there instead of just being alone. But the good thing was, even though the visitor policy was kind of like null and void, if there was a patient that was actively dying and they knew this, they would call family, but only 2 people could be at the bedside. And sometimes nobody could be there. And so we would have to FaceTime them on the iPad and just like show them their loved one in the bed. And you can see in their faces, like how distraught that they were, because they couldn't be there physically. And so it still sends chills through me, because it's like, man, these people want to be there, but they can't. It's for safety reasons. Mm-hmm. But just being able to even have that access with the iPad and them being able to see their loved one, it gave them some kind of solace, but it's nothing like being there in person.
Sure.
And I would amplify your message, Janna. This isn't just about COVID patients dying. This is about everyone who's got a deadly illness, whether it's a heart attack or cancer or end-stage lung disease or anything else, strokes. They still weren't able and are now just getting to the point where a single family member can come in to see them. Yep. And that is very, very difficult. It's difficult for staff caring for patients. It's difficult for physicians caring for patients. It's difficult for the families, obviously, as you mentioned. And the connectivity that we have wasn't ready for this. It's getting there. It's getting there.
Sure. Another question in our chat from Brett Gordon. Brett wants for us to talk about nutritional and holistic and complementary approaches to reduce risk within our communities. Brett writes, everyone seems to be focused on reliant and external treatments, prophylactics, and vaccines, but Brett's interested in knowing more about how we boost our immune systems in a way that we can navigate this virus and future viruses?
Well, it's a tough question. So I do think that nutrition and holistic methods to make one healthier obviously are important, and that's great. But I think the bigger issue is to not get sick in the first place. And what can we do to prevent getting a virus into your body? Once it is in you and you have an infection, it is wonderful if you are healthy, but even healthy people are dying from this virus. And I think it is better to prevent that virus from getting to your mouth or your nose, your eyeballs in the first place. So I do think it is, that kind of goes along with what we were talking about earlier with some of the underlying medical conditions with diabetes and asthma, and a lot of those diseases are related to nutrition and lifestyle things that can be modified. And that's great to emphasize that. I think it's important to emphasize. It does not help them right now. That's great for future infections and things like that. But in terms of right now, we have a pandemic amongst us. We're not going to reverse everyone's diabetes or obesity this week. So we need to think about what can we do? What's the reality of the situation right now? And that's where I think that preventatives like masks and the physical distancing are important. And in the short term, the vaccine would be wonderful, because if that can prevent the infection from ever taking hold, and that's how I think we're going to get over this pandemic. But in terms of future pandemics, like Paul is alluding to, that is important.
Sure, yeah. We have another question from Ann Harding. How do you feel about schools reopening, which parallels Marilyn Meredith's question from an educator's perspective, getting ready to return to the front lines of teaching? What are your suggestions to help educators who will be in the classroom? And could you talk as a group about young kids contracting COVID as opposed to adults contracting COVID? I'm giving you 3 questions all at the same time, but I think they're related.
Yeah, they are. I won't be, as I mentioned before the program, I won't be surprised if our school systems stop as of Halloween, maybe even earlier. And it's a part of that is because of the teachers not being able to be there. It's like healthcare workers. If we run out of healthcare workers, we can't manufacture them quickly. The same thing as with teachers.
Sure.
We run out of teachers and they're sick for 10 days, 2 weeks, 3 weeks with this virus. There just aren't enough people to be able to support them, to fill in those classrooms. So that's number one. Number two, I think this is going to change how we do education. I'm not a trained educator. Yeah, I educate every day in my office and every place else, but I'm not a trained educator about the concepts of education and how we do that. I think this gives us an opportunity to really strongly look at that and be able to change how we do education. How should teachers protect themselves? Professors, teachers, they're all teachers at one level or another. It's the same way. The chances of acquiring this disease have to do with proximity and duration of contact. If you can decrease duration and you can decrease proximity, increase get further away. You're gonna improve the likelihood that you won't catch this disease. And as Ben mentioned, not catching it is the name of the game for this particular pandemic.
Sure.
And that's what we have to work on. If you put 30 children, and that's up to the age of 17 or 18, in a classroom with a teacher, we got problems. And I don't know how we're going to not do that. There's the A's and the B's, and some people are remote for part of the day, and some people are in the classroom part of the day. it's still about proximity and duration. And when you're in there for an hour, that's a long duration.
Yeah, I completely agree. I mean, I will just start by saying I'm biased. I do not have children. If I had children, I would probably be desperate to get them to go back to school in the fall, but I don't. So I think of it more as an emergency room doctor, which is exactly what Paul said. You cluster children together, 30 in a room for 8 hours straight. They're breathing the same air. I don't think there's any question what's going to happen. Of course, the numbers are going to go up. And so do I think they should reopen? That's not really for me to say. I can just say I think it's pretty clear what's going to happen when they do reopen. That said, I have some friends who are teachers, and they have asked me that exact same question: what could I do because my school is opening and I'm scared? And I tell them to take the exact same approach I do at work and the same approach I take at home, which is that I personally wear an N95 mask. I do not take it off at any time. Any air that's coming in and out of me is going through that filter, and that's what I do to reduce my own personal risk. And second of all, I think there's more and more going to be an emphasis on air quality and the fact that this virus probably is airborne more than it's been publicized. And if it is possible for a school classroom to open the windows to have open moving air, that's helpful. Or if they could have classrooms outdoors in good weather, that is helpful. But in October, it's going to be cold in Illinois. Or if you're in Phoenix, it's 110 degrees. They're not going to want the windows open either. So what I've been telling my teacher friends is to get an air purifier with a HEPA filter, something that's going to exchange that air and can potentially be filtering out a virus. I mean, I sent one to my 96-year-old grandmother who's in a nursing home in central Illinois, and she can't get away. So I say, just stay in your room and run this machine all day long and keep the door shut. And so I think things like that are at least an option where we can reduce our risk. And if we can reduce the viral load in the environment, then it's a lower infectious rate and lower severity of disease, because this does affect kids too. It's not as lethal as to someone who's in their 80s, but I mean, my hospital, we've already seen a disastrous case with a child with COVID. It happens, and you get one disastrously sick child per school. It's just a matter of time before that's gonna catch up to everyone.
Sure. Well, we're approaching the 1 o'clock hour. We have two comments and questions in the chat, one from Michael from Seattle and one from Gina Baldacci, both talking about how other countries seem to have done this better in terms of containing the pandemic, and both really want to know, what's our new normal going to look like? So let's make that our final question for the afternoon. No need to talk politics in terms of what's unique about the U.S., but what's ahead for us?
It's not about politics. It's about leadership.
Mm-hmm.
And it doesn't make any difference if you're Republican, Democrat, Independent. Leadership needs to lead.
Mm-hmm.
And I think we've not seen that very strongly from our federal government.
Yeah. So what do each of you see in terms of our new normal? You mentioned, Paul, this is not the end of this pandemic. What should we envision for health and safety of the U.S. going forward?
Number one, I think we've learned how to wash our hands a little bit better. Number two, I think we're going to keep our hands away from our face a little bit better. Number three, there's nothing the matter with masks. I got a cute one. I wear it all the time. I think, I really wanted to go into the mask business, in early March and, patent the thing, but that wouldn't have worked very well. Yeah, but I think these are going to be a new norm for social interaction and physical interaction.
I agree with Paul. Masks are definitely the new norm. There are a lot of different fashion brands that are making like super cute and fashionable masks for the ladies who want to match, and the fellas too who want to match. One thing that I'm already seeing, like in my travels day to day, is people are holding each other accountable more for being clean and being physically distant. Like if you're in the grocery store line and somebody's standing a little bit too close to you, like, hey, can you step back a few feet because you aren't 6 feet from me? You know, I've definitely noticed that a lot is the accountability factor. And I mean, everything socially, as far as going out, like concerts, restaurants, things like that. Things are still in the works with trying to figure out how we can still enjoy the things that we love, but being safe. A lot of places opened up a little bit too quickly or never closed at all. I know here in Illinois, our governor has done a really good job with things, and I'm very proud of that. But it's still a work in progress, but things are going to be different, but I feel they're going to be better.
Ben, you have the opportunity to make the final profound statement about the new normal.
I have nothing profound to add to what they already said. I agree. I think masks will be commonplace. I think even presuming, let's say there is a vaccine and let's say we get over this pandemic, I think that a decent percentage of people will make this common when traveling or when they're going to a group event. I think that probably will be the new normal. And as we've all gotten used to wearing masks, I mean, I remember feeling ridiculous the first time I put a mask on, and you feel like you're a germaphobe or something wearing it. But now when everyone's doing it, it's not a big deal. You don't even notice it hardly anymore. And I think that will become more common.
Sure. I am grateful for the time each of you have spent with us. I understand that Adrienne is going to rejoin us and give our audience directive on how they can find this taped webinar, as well as how they ask additional questions.
Yes. Thank you so much, panelists and Dr. Folse, for being here, taking time out of your very busy and stressful schedule. I'm really glad to hear that you are feeling appreciated. I'm sorry that it took a pandemic for you to feel that way. But I do really appreciate your time today for this important conversation and your commitment to Illinois Wesleyan and giving back in this way. So thanks also to those of you who joined as audience members for this episode. You will be receiving an email with a survey and also a link to the recording. You can find all of our Titan Talk recordings on the Illinois Wesleyan website that'll be popping up here shortly. And so I want to hope to see you in a future Titan Talk. Everybody, get yourself a cute mask, and we hope to see you sometime soon. All right. Thanks so much. Thanks, everybody, for a great conversation. This was wonderful.
Agreed.
Oh, yes, it was.
Yeah.
Thank you.